So I'll start from the basic and try to take you to the various assessment, history, important points in history, investigations and assessment, then something about what maneuvers generally we do. I will not touch on the pharmacotherapy because that will not be apt for you. So I'll try to touch on the maneuvers that we try to do and what are the various surgeries which people are trying in this, and I'll come to the latest of what's in research going on regarding the use of AI and smartphones and technologies in that. So if anything is going little boring, because it will be, it's very, the basic physiology of Vertigo is very hardcore and difficult to understand because it's very complex. So I have no problem. You can just raise a finger and you can just cut that part and I'll go to the next part, right? So I just hope it's good experience for you. So we all know what's vertigo, a sense of spinning or motion, okay? And either you are rotating or you feel the surroundings are rotating. And the animation that I have put down is that vertigo patients, they go from doctor to doctor and they may not get relief. So they may go to an ENT person, they may go to a physician, they may go to a neurologist, then they go to a physiotherapist, or they may go to an alternate medicine, and then so the basic point is that you need to have a collaborative approach, because when we see the physiology, it's not one organ that is involved, and there can be many systemic diseases, like it can be stroke, which is just presenting with a vertigo, or it's some cardiac problem, which is a syncopal attack, or it can also be simple anxiety that patients are just feeling I am feeling dizzy all the time. And so when the patient gives us the history, sometimes they also feel dizzy, whether he is actually dizzy or is not dizzy, and they don't give us real history. Sometimes you can have variation of migraine with vertigo. Then again, it also you think then people with eye problems also at times they can feel dizzy because they are trying to fixate on a thing and they are feeling some imbalance. So I'll take you to the journey. So now we have to understand that it is a complex system of maintaining the balance of the body with respect to our surroundings. So your central nervous system is in the center, commanding and controlling and trying to balance everything. And so where does it receive the input from? It receives the input from the eyes. So what are the eyes doing? Eyes are telling us that how are our surroundings, right? So they are giving that input that this like whatever is moving gives a sense of motion, it's moving, and whatever is stationary, the eyes tell that it is stationary. Okay? Then comes all our part of our central nervous system. There is peripheral part which is give you inputs. Like if I touch here, my hand sends a sensation. My feet are on the foot, they give me a sensation. So they will tell us that how are we grounded. So my ground, if it's moving, so my all senses will give me input that this is moving. Okay, and then comes your our part, our ear part, that you have your balance organ, which is your labyrinth. So the labyrinth will give that what is the position of your head with respect to your trunk and body. Okay, so like if I rotate on one side, my labyrinth is giving that input that with respect to the body I am tilted to one side. So in this way, all these inputs are very important in maintaining the balance. So if either of these systems is, and you can understand when so many inputs are coming from almost all of the part of the body, so if those inputs are not coming properly, they have some end organ problems, then again the patient is going to feel dizzy. Okay, and there will be many systemic causes which can affect these inputs. So when we are evaluating a patient of dizziness, it's not always in the ear and it's not always in the mind. There can be something else. And how it is important, like when we have patients who are geriatric age groups, old age groups, so all these, their balance system is Also controlled by the inputs they're getting, or patients are diabetic or having neuropathy. So they will have weight imbalance while walking or certain situations. So there will not be a single drug that we give to this patient and he will be fine. So that is not going to happen, and I think those are the most difficult patients who have degenerative diseases in their CNS, where we cannot give them. We have to just rehabilitate them. We cannot cure their vertigo. So this is just the depiction of the same whatever I have told. You have an input from these receptors like vestibular, visual, somatic, and you have the central processing system consists of vestibular, cochlear, nuclear complex, your reticular nuclei, your cerebellum, and this will send output to your oculomotor control of the cranial nerve, the eye movement, and spinal motor control by your 11 nerves. And they will also control your neck movements. So this is just to stress it is a complex anatomy. So I just start with the basic. We all know that you have a bony labyrinth which has a perilymph, and you have a membranous labyrinth where you have cochlea and you have your semicircular canals and you have your vestibular apparatus consisting of utricle and septum. So just a diagram to stress upon where these this is a bony labyrinth, this is a membranous labyrinth, and you have your semicircular canals. This is the location of the utricle, saccule, and this is the turns of the cochlea. Hello. Okay. And I just want to highlight here that the endolymph, you know what is, there is a perilymph and there is an endolymph. So the endolymph has high potassium and low sodium concentration, and this endolymph is secreted by the stria vascularis and the dark cells situated in the ampulla, utricle and the crustum. And you know this is important, this extra secretion and decreased absorption is important in the disease called as Meniere's disease or hydrolymphatic hydrops. Again, we may get patients with having Meniere's disease. Again, the treatment is not that short of that because of this intricate complex balance which is there of the production and the secretion. So again, that's a difficult area. So about the semicircular canal, I'll just show in a diagram that we know that you have an ampullated end and a non-ampullated end, and then you have the crista there, and in the crista you have a horseshoe-shaped gelatinous structure and a membrane-like cupula, and you have hair cells, and this movement of the diaphragm of the cupula that gives you a sense of rotation. And why does it happen? Because the fluid, the endolymph will move with your rotation, and that will displace this cupula which is situated in the ampullary end of the semicircular canals. Okay, and these semicircular canals, now the lateral, we have three semicircular canals, lateral, superior and the posterior. So the two lateral, they act together, and or the other canals, so one side posterior will be concentrating in a parallel axis to the other side, the inferior. Okay, so that is how this diagram is showing you how these canals are oriented. Okay, so each canal you have an orientation on the opposite side. So when we study the canals, we have to keep this anatomy in mind. So this is just showing you the same what I told you, that when we spin or we rotate this cupula, it deflects back because of the fluid which is flowing, and this membranous labyrinth, it is tethered to the bone, so that will be stationary, and the fluid force will move this cupula and give you that sense of rotation. So like when a canal is excited, it will fire more. Okay, and what happens when it fires more, the eye will deviate to the side, and then the opposite side will send signals to restore the eye to the neutral position. Okay, so that forms the basis of your what we say nystagmus, like the deviation, the examination finding of patient saying vertigo, and you see the eyes are deviating. That's the nystagmus, and it has a slow component and a fast component. So the slow component is a component which is to the disease deviation, and the fast component is because of the corrective action taken by the body to restore our vision to your target. But we generally say that nystagmus directed to the site which is a fast component because that is more evident. So coming to the utricle and saccule, so we saw their locations. So they also have a sensory epithelium called as macula, and it has lot of hair cells, and they are also called as otoliths organ because they have calcium carbonate crystals or otoconia which are floating in the gelatinous matrix. I just show you the diagram. So this diagram is showing you the difference between the cupula of the macula of the semicircular canals and that of the utricle and the saccule. So there we have seen the gelatinous material and a horseshoe structure. Here they are oriented with cells in a gelatinous material, and we have calcium carbonate crystals called as otoconia on top of this. Now these otoconias are the ones which dislodge from their position and they go into these canals and they give you the sensation of spinning, and which is the most common cause of the vertigo, which is called as benign paroxysmal positional vertigo. Okay. So are all of the maneuvers for the benign paroxysmal positional vertigo or the BPPV is to somehow bring these particles from the canals, which wherever they are, into this utricle and saccule so that they settle down here and they don't float freely in those canals where you have that endolymph moving all the time with the motion. So coming to just few facts, that the utricle, it sends the lateral tilt of the head, and the saccule, it senses the front to back tilt. Okay, and these have central stripe. So this is telling you the ambulation of the utricle and saccule. So they have a central stripe which is called as a striatum, and these hair cells, they in saccule, they are directed away from this central striatum, and in the utricle they are directed towards the central striatum. So this difference in the orientation gives the sense that when it is tilting or when it is bending forward, that those cells will fire off and give you that signal to the brain that okay, the movement is occurring in this angle. Coming to the central vestibular system, so I've already told you that it will coordinate the head and neck movement, it will maintain the upright position, and it will direct various reflexes. And there are two different pathways. We have a lateral vestibulospinal pathway and a medial vestibulospinal pathway. So obviously the lateral will relate to your lateral tilts, and your medial will, right, when you are walking, and so forward and back tilt will be from the medial vestibulospinal system. Then there is something called as vestibulo-ocular reflex. So like when we, if we are looking at a point in front and we deviate our head to one side, so your body will try to move the eyes in a way that they will focus on your target. Okay, so that your image is forming on the fovea. Okay, so this is called as vestibulo-ocular reflex. So that is why when we have nystagmus, we ask the patient to see at a point, and then the eyes deviate and the body will try to again come on that target, and that will give the sense of nystagmus to the patient, and that we can see. So this diagram is telling you that when on the right side you are having excitatory signals on the right side to the eyes, then from the opposite labyrinth you have inhibitory signals to the opposite side, so that you have a sense of the eyes can maintain a neutral position and they can focus the picture of the target on the fovea. Now I'll tell you something about the compensatory mechanism of the central nervous system. So central nervous system will try to balance this difference of inputs from the two labyrinths. So one is excited, it is firing more, or one is diseased, it is not firing. So you have a disbalance. So it will when this situation occurs, so there are three methods: compensatory mechanism, acutely with the CNS will try to do. So one is the vestibular clamping, that will try to stop the one which is firing more, and second is restructuring, and the third is the fine tuning. So what happens in vestibular clamping? That will try to it will try to reduce firing from the labyrinth, which is firing more. Okay, and so if it is very excited, it will tune down the resting tone of the vestibule, so that what will it help? It will help in decreasing the nystagmus, decreasing imbalance, and we have, you know, a lot of people associated with vertigo, they will have nausea. So it will calm down because the firing of those impulses is coming down, so the patient will have less nausea.
मैम ये physiological process में होगा या?
Yeah, ये physiological. Like whenever somebody is having some problem, the CNS will try to do all these things. That is why, you know, people will have acute nystagmus and after some time they will be okay, because the CNS will also balance. It's not that if we don't give drugs, the patient patient will be, you know, having vertigo for long time, because CNS will come up in the role, because that's the supreme role to balance signals from everywhere.
So is there any attack of vertigo in that patient, specific patient?
Yeah, so in any patient, this is I'm telling you, when the patient is having vertigo, what will be the CNS doing? CNS will try to balance. So it will just try to shut down the extra firing labyrinth. Okay? Because that's you know, tilting the balance. Okay, so it will stop firing from that labyrinth. Then what will happen? Then there will be restructuring, means it will try to make new connections. Okay, that so that new pathways come up, and the one which is either firing more or firing less, you have alternate. So we should have equal balance of inputs. So the CNS, this is a disease one, the body doesn't need it. So the CNS will try to you have new connections, so that the body is getting equal signals from the both sides. Okay, so it will start restructuring, and then last it will try to do fine tuning, where so that everything becomes smooth, and the labyrinth, I should stress that the labyrinth which is damaged, it will remain unutilized. Okay, so we clamped it, and then अभी उसको हमने काम उसका बंद कर दिया, but उसका काम किसी को देना पड़ेगा ना, क्योंकि वो तो फायर कर रहा था, तो किसी और कोई और कनेक्शंस बनाने पड़ेंगे. ये काम नहीं कर रहा है, और कनेक्शन बनाओ ये इधर से, ताकि हमारा सिस्टम ठीक से चले. इट इज दैट, इट विल रीस्ट्रक्चर एंड देन इट विल फाइन ट्यून द सिस्टम, सो दैट, क्योंकि हम कोई चीज़ अगर काम कर रही है उसको हमेशा के लिए बंद नहीं कर सकते. यू हैव टू हैव अ ऑल्टरनेटिव. इफ माई AC नॉट वर्किंग, माई फैन शुड वर्क. सो इट विल जस्ट इमीडिएटली टू स्टॉप किया, फिर उसको रीस्ट्रक्चर किया, एंड उसका काम किसी और को दिया, नए कनेक्शंस बनाए, सो दैट हमारे पास बॉडी का बैलेंस मेंटेन करने के लिए अच्छे से स्मूथली सिग्नल्स जा रहे हैं. सो दैट वाई इट इज सेड कि जो लैब्रिन्थाइन सेडेटिव्स होते हैं जो हम देते हैं, दे शुड नॉट बी गिवन ऑन अ लॉन्ग टर्म. अभी किसी को चक्कर आया, ठीक है, अभी आपको फटाफट दे दो, उसको चक्कर कम हो जाए. बट इफ यू आर गिविंग इट इन अ लॉन्ग टर्म, सो दिस न्यूरल मैकेनिज्म यू विल हैम्पर. क्योंकि आपने तो उसको सुला दिया, अब वो CNS को जो इनपुट जा रहा था कि भाई ये ऐसे काम कर रहा है, इसके अकॉर्डिंगली एडजस्ट करो, तो वो तो एडजस्ट नहीं करेगा. तो इट इज लाइक acute sedatives should be given 3 to 5 days, and then after that we should just stop them and put in on some long term things which will not hamper this. So some few terminologies of, you know, what types of dizziness experienced by a patient. So in true vertigo, it is like you have illusory sense of motion. So a spinning sensation is common, but not always. What will be the duration? Duration will be seconds to week. And when we say true vertigo, it will be frequently associated with nausea, and disease mechanism is disruption of the vestibular pathways. Then some patients will say कि we just feel कि हल्का हल्का लगता है, that's called as lightheadedness. So generally this lightheadedness it may be because of syncopal attack, and patient will feel that the consciousness is going and he may faint also. So this can also, duration can be from seconds to minutes. and patient may feel a flushing sensation and some visual changes. So this can be because of transient reduction of cerebral perfusion. Like a patient is having, you suddenly get up from the bed and you feel dizzy. Okay, so that's because your blood has gone into the periphery and it's not gone up. So some people are prone to postural hypotension. Means whenever they get up, the BP just shoots down. Or when you are sitting on the ground, your all the blood is in the peripheries and your pump is not active, and you just get up and then the perfusion is not there. So you can feel that lightheadedness, and I'm sure we all of us have felt it at some point of time. Then there can be disequilibrium, where the patient feels that he finds it difficult to maintain the balance. Now this can be, most common in geriatric patients or patients having CNS problems, where they have to climb the stairs, or they have to go down this ramp, or they are on an escalator, and they find it difficult to maintain their balance. So they can give you a history that I fall down also. Okay. Generally, our patients of peripheral vertigo, labyrinth, and they'll be able to take rest and they will be okay. Patients of CNS problems or geriatric with multiple, neurological problems, they give you a history that we are not able to maintain the balance and we fell down. Okay. So that's more common. So that indicates that there are multiple sensory deficits in the patient. So this is just showing you what the various symptoms of the patient can be. He may just feel dizzy, or when he try to maintain his balance, he's having problem. And here, this third row, generally patients with like Meniere's disease, they have a sense of fullness, they have tinnitus, and they also have decreased hearing at the time of attack. Okay. And then after the attack, their hearing is slightly better. So coming on to the difference between a peripheral and a central cause. So in a central cause, the onset may be gradual. तो पेशेंट से बोलेगा कि हाँ ऐसे थोड़ा थोड़ा चक्कर लगता है, पर एक पॉइंट ऑफ टाइम आपको नहीं बता पाएगा. अगर कोई पेशेंट हमारा पेरिफेरल बताया हुआ है जिसमें लाभ, और वो बोलेगा कि मैं बस सो के उठा और बस मुझे अचानक चक्कर आने लगे, या मैंने बेड पे ऐसे लेटा था और लेट के उठा तो मुझे चक्कर आ गया, या किसी ने बुलाया था मैंने सडनली ऐसे टर्न नेक रोटेट किया और मुझे चक्कर आ गया. तो अगर कोई पेशेंट हमें वैसा हिस्ट्री दे रहा है तो वी नो कि इसको पोजिशनल कोरिलेशन है और इसको सडन ऑनसेट है, इसका मतलब कि इसको पेरिफेरल डिजीज है. और कोई बोल रहा है कि मतलब बहुत टाइम से ऐसे चलता आ रहा है, अब ज़्यादा लग रहा है, तो दैट मीन्स कि उसमें उतना पेरिफेरल कंपोनेंट नहीं है, उसमें सेंट्रल कंपोनेंट है. और ऑब्वियसली जो मीनियर्स वाले पेशेंट होंगे वो आपको बता देते हैं कि आपको एपिसोडिक आता है, फिर जाता है, फिर सुनाई देता है, फिर कान में आवाज़ भी आती है, तो यू नो कि एक वो मीनियर्स की तरफ पॉइंट कर जहाँ पे आपका हियरिंग आ जाता है. एंड पेरिफेरल में ऑल्सो यू हैव मोर चांसेस ऑफ नॉजिया एंड वॉमिटिंग. some points की अगर hearing spared है तो what can be the cause? It can be vestibular neuritis, you can have head injury or hearing involved है, so you can have head injury, you can have Meniere's, you can have fistula, and you can have viral infections of the inner ear, you can have vascular stroke, where if it's involving the labyrinthine part, you can have hearing involved. So what will be the accompanying features of the various causes? So in the positional, like if it's positional, so you know that it's BPPV or it is orthostatic hypotension. If it is paroxysmal, then maybe vestibular cause is there. If there is a migraine history, so you know that along with migraine, this patient is telling that I am feeling dizzy, so it can be vestibular or basilar migraine. And I've already mentioned about the Meniere's and ataxia. Then there's something called as transient ischemic attacks, which is because of the microthrombus going into the brain. So patient with cardiac disease, and then they are telling that they are having this, then they should be very well screened. There's something called as Doppler study, that what is the block in the carotid arteries, and maybe that is causing these TIAs. Then some people who are anxious, they can have panic attacks. I think we have just stressed on these things. I just mentioned about this Tulio's phenomena. So this tulip phenomena is like when there is loud sound exposure, the patient feels dizzy, and the most common cause of tulip phenomena is superior semicircular canal dizziness. So what happens? The bone over the superior semicircular canal is dizziness. So the sound which is going to the ear, it is directly stimulating the semicircular canals, leading to that sense of vertigo. So it's rare and difficult to diagnose. You need to have a good, scans which can tell you that this bone is decent. So if patient is giving that history, you can screen him from decent superior semicircular canal. So a few points about nystagmus. So it is involuntary eye movements and it can be of various types. Like it can be a pendular one or phasic. It can be spontaneous or induced. It can be horizontal or vertical. So there are two laws in this. One is Alexander law, which says that when we say the patient is having nystagmus, we have to also say what is the degree of nystagmus, whether it's first degree, second degree, or third degree. First degree means in the direction of fast component. I told you when we say the nystagmus has a slow component and a fast component. Then second degree is where it is in the primary gaze also the patient is having nystagmus, and third degree is where in association with these two, even in the direction of slow component the patient is having a nystagmus. And there is second law, again it's like it has three laws in this Evol's law. So they say that the head and eye movements always occur in the plane of the canal being stimulated and the direction of flow of the endolimbs. Okay. So why this is important? Because when we are evaluating our patient, तो उसका nystagmus और eye movements किधर जा रहा है, that will guide us कि कौन सा canal involved है, because we see कि वहाँ पे 3 canal है और हमारे पैर अब भी कर रहे हैं, है ना, जो इधर का सुपीरियर है उधर से पोस्टीरियर से है और इधर वाला जो है ऑपोजिट साइड का सुपीरियर से पोस्टीरियर से पैर अप कर रहा है, तो उनका प्लेन सेम है और साइड कौन सा है. तो बाय कीपिंग दिस लॉज इन माइंड वी कैन गेस कि अच्छा ये वाला कैनाल इन्वॉल्व है. अदरवाइज कोई ऐसा टेस्ट तो है नहीं कि मैंने ब्लड टेस्ट कराया बताया इसका तो इस कैनाल के अंदर पड़ा है, या हमारे रेडियोलॉजी इतनी अच्छी हो बोले कि इसके इस कैनाल में यहाँ पे फ्लोट कर रहा है. तो अभी तक वैसा नहीं आया. मे बी विद टाइम एज द टेक्नोलॉजी इज प्रोग्रेसिंग इट कैन टेल अस कि वहाँ फ्लोट कर रहा है, तो हमको पता है कि वहाँ फ्लोट कर रहा है, उसको ये वाला मैन्यूवर करना है, पेशेंट विल बी फाइन. ओके, सो दीज लॉज आर जस्ट टू हेल्प यू कि हाउ वी कैन फाइंड आउट कि कौन से कैनाल में वो ओटोकोन या क्रिस्टल्स फ्लोट कर रहे हैं. ठीक है. देन सेकेंड इज कि जो हमारे लेटरल कैनाल होते हैं, तो हमने भी रिवाइज किया कि उनमें एक एम्पुलरी एंड होता है ना, एंड एक नॉन एम्पुलरी एंड होता है हर सेमी सर्कुलर कैनाल का. तो जो एम्पुलरी एंड होता है लेटरल कैनाल का, अगर उसमें एम्पुलोपीटल फ्लो है, मीन्स एम्पुला की तरफ अगर एंडोलियम जा रहा है, तो दैट कॉजेज अ ग्रेटर रिस्पॉन्स और ग्रेटर फायरिंग देन द एम्पुलोफिगर. वी ऑल नो पीटर एंड फ्यूगल फ्रॉम आवर फिजिक्स नॉलेज. बट जो वर्टिकल कैनाल है उसमें इनका उल्टा होता है ना. तो जो वर्टिकल कैनाल है उसमें एम्पुलोफ्यूगल फ्लो विल प्रोड्यूस अ स्ट्रॉन्गर रिस्पॉन्स रादर देन एम्पुलोपीटल फ्लो. सो दैट इज अ थर्ड लॉ. नाउ जैसे हमने बोला था कि पेरिफेरल और सेंट्रल कॉजेस होते हैं वर्टिगो के. सो द nystagmus also the origin can be peripheral or central. Now by seeing the nystagmus, how can we say whether it is peripheral or central? Okay, so some things can guide us. So what are those things? So अगर एपिसोडिक है तो इट विल बी पेरिफेरल, और अगर सेंट्रल है तो कॉन्स्टेंट है. जैसे हमने देखा था कि जो पेरिफेरल है वो पोजीशन से अफेक्ट होता है. तो हम जब पेशेंट को उस पोजीशन में लाएंगे या पेशेंट हमें इसलिए देगा कि हम ऐसे करते हैं तो होता है. ठीक है. और जो सेंट्रल वाला पेशेंट होगा ना, हमें देखा तो उसको इतने सेंसरी इनपुट्स की प्रॉब्लम है कि उसको तो सब टाइम ही उसको nystagmus होता रहेगा, या कोई उसको अभी स्ट्रोक हो गया है तो उसको इट इज़ नॉट डिपेंडेंट ऑन द पोजीशन. उसको तो जहाँ पे डैमेज किया है तो पेशेंट विल कीप ऑन हैविंग nystagmus ऑल द टाइम. एंड द सिवियरिटी ऑफ द पेशेंट सिम्टम विल बी प्रोपोर्शनल टू द nystagmus इन पेरिफेरल. इसको बहुत ज़्यादा आँखें लगी है, उसको बहुत ज़्यादा नौजा मुझे पड़ा है, उसको हल्की हल्की लगी तो उसको भी प्रॉब्लम नहीं है. और अगर सेंट्रल कॉज है तो दिस विल बी डिसप्रोपोर्शनल. यू नेवर नो कि उसको कितना बड़ा स्ट्रोक हो रखा है और उसके बस हल्का हल्का निस्टैग्मस हो रहा है और कुछ पता नहीं चला. तो इट इज डिस्प्रोपोर्शनेट टू द डिजीज सिवियरिटी और पेशेंट को कुछ प्रॉब्लम नहीं हो रही है. देन एक्सेस ऑफ द, जैसे मैं बोला कि निस्टैग्मस कैन बी हॉरिजॉन्टल, वर्टिकल, रोटेशनल. सो मोस्टली पेरिफेरल में क्या होता है, हॉरिजॉन्टल और रोटेटरी होता है, और सेंट्रल में क्या होता है, डायरेक्शन चेंज हो जाता है, कभी ऐसे ऐसे हिल रहा है, कभी ऊपर हिल रहा है. तो दैट्स अ कैरेक्टरिस्टिक ऑफ सेंट्रल निस्टैग्मस. देन हमने जो बोला था कि स्लो एंड फास्ट फेज होते हैं, तो पेरिफेरल में वो फॉलो होते हैं, बट सेंट्रल में वो उतना फॉलो नहीं होता है. देन व्हाट इन द लेटेंसी, कि हमने किसी पेशेंट ने बोला कि मुझे इस पोजीशन में निस्टैग्मस, तो हमने उस पोजीशन में इसको रखा, तो थोड़ी देर बाद निस्टैग्मस शुरू हो गया. तो दैट इज 10 to 20 सेकेंड. बट सेंट्रल में ऐसा कुछ नहीं, बिल्कुल हो ही रहा है ना. देन डायरेक्शन जनरली पेरिफेरल में फिक्स रहता है कि फास्ट कॉम्पोनेंट टुवर्ड्स दिस साइड एंड स्लो कॉम्पोनेंट टुवर्ड्स दिस साइड. बट सेंट्रल में ऐसा नहीं है, उसका डायरेक्शन चेंजिंग होता रहेगा. ड्यूरेशन पेरिफेरल में ब्रीफ होगी और थोड़ी देर बाद वो कम हो जाएगा या बंद हो जाएगा, क्योंकि उस पोजीशन में वो हमारा निस्टैग्मस, वो वर्टिगो और निस्टैग्मस एग्रीवेट हुआ और थोड़ी देर बाद वो कंपनसेट हो जाएगा. पर सेंट्रल में ऐसा नहीं होगा कि हमने कोई पोजीशन करी तो वो कम हो जाएगा, नहीं, वो नहीं होगा. एंड ऑब्वियसली पेरिफेरल वाले में आपको ह्योरिंग एंड टिंटस मिलेगा और सेंट्रल में नहीं मिलेगा. सो नाउ one video which will tell you whether nystagmus can be direction changing or not. Voice is not coming in the second. Voice is not coming.
देख जैसे एकदम कहाँ गया.
So this showing you the primary place where the patient is looking. And you can see a nice nystagmus with the
It's jerky.
so the fast component is towards the left side. Okay, and now she's looking on the opposite side,
That's
and
not
you can see the nystagmus has decreased.
decreased. Yes.
So
That is jerky type, no?
yeah, this is jerky type.
Mm.
And there's something called as physiological nystagmus. So if we see at the extreme gaze, so we can get some nystagmus. But if we keep a finger at 30 degree and patient is having nystagmus, that's pathological. But beyond 30 degree, that's called as end gaze nystagmus. So here this boy, you can see that when at central gaze we're not seeing much nystagmus, but when he is looking extreme lateral, you can see there is some nystagmus. That is a physiological nystagmus. So which when you look at the extreme gaze, you can see that nystagmus. Okay, and it's coming on both sides. When you're looking on the left and when you're looking on the right.
It's like physiological. No?
Yeah. So end gaze nystagmus. So if the person is having nystagmus at extreme gaze, then that can be physiological. So when we are testing for nystagmus, we don't test at that extreme gazes and say the patient is having pathological nystagmus. So you can have physiological nystagmus at the end gauge. So coming on to the management. So again, I told you management means investigation and treatment. I think in vertigo you need to have a very comprehensive history so that you can reach to some diagnosis. So we've already mentioned these, that mania will be hearing, migraine will give you a history of photophobia or phonophobia, and if you have CNS symptoms, like if you ask the history of any previous CNS complaints. And then you can have a detailed history of onset, कि सबसे पहले कब हुआ, अभी कैसा है, duration, episode, symptoms in between, how is the recovery. जो हमारे peripheral vertigo होते हैं, वो तो बीच में patient okay रहता है, अगर वो positions को avoid करे तो patient is okay, will not have. But अगर central में ऐसा नहीं होगा, it will keep on going on. And whether there is progression, any relieving factors, any associated symptoms. So अगर nausea vomiting है तो we should think कि उसको migraine वाला component है. Any ear disease history, because your ear diseases of otitis media, like the unsafe type of otitis media, the squamosal otitis media, can erode the lateral semicircular canals, and those patients can get vertigo. And if it can also be after the surgery also, we've done some surgery and then we have damaged that organ, then also patient can have vertigo. And any patient with ear discharge, if he has started having vertigo, then that is a red signal for the doctor that it has gone into the inner ear, and surgery, imminent
हेलो
surgery
लिखिए
should
मम्मी
be
जल्दी
done early.
लिख के
Then
जल्दी
you
लाओ
have to
लिखती है क्या
take a medication history, whether how crippling is this vertigo for the patient. Coming to the examination, again we have to have a detailed ENT examination along with cranial examination and neck examination. So then special note of we have to take of the whether the nystagmus is spontaneous, like we're examining that patient and he's having nystagmus, or we have, if there is no spontaneous nystagmus and patient is giving a history कि नहीं कुछ होता है, so we have to induce the nystagmus. So there are various tests that we can do to induce those nystagmus. So what are those tests? There's something called as caloric test, there is fistula test, there is positional test, there are rotational tests, there are optokinetic tests, and then there are two other tests called as electronystagmography, which will tell you about the vestibulo-ocular reflex, and then there is cranioportography, tells the movement of the patient. There are various methods of recording these eye movements. You can do electrooculography, you can have magnetic coils, you can do video nystagmography, and you can have infrared technology for documenting the eye movements. Then what is caloric test? So as this is the induced type of nystagmus test, so we want to excite the labyrinth by putting hot or cold water into the canal. And if the patient is having perforation, we can have cold air that can be put in, and we can see
Like,
the nystagmus being.
how much quantity we can put, like water?
No, as we can we can hang it in a bottle like this, and at 30
अच्छा
degrees and 44 degrees, and we can
Continuously.
irrigate, and we have to see that in 10 to 20 seconds, if it's a peripheral vertigo, the patient will start having nystagmus, and then we will document the onset of the nystagmus and the end of the nystagmus.
Cold means how temperature?
It's 30 degree and 44 degrees. So the normal temperature is 37. So 7 degrees either side we can do it.
Okay.
Then actually we also along with this we do something called as we make a tabulated chart which is called as a Clausen's butterfly chart, and which by the machine can tell you that what is the code, what can be the probable site of lesion in this patient. Then you can do a cranioportography. So this tells us that how the patient is moving. So in this what happens, the patient is put in a room and there's a machine is put, and on the top the cap has lights, and there will be a camera on top, and when the patient will be moving with eyes closed or eyes open, these movements will be recorded. Here you can see that these movements are recorded, and this patient is almost going in a straight line, and the second patient you can see this patient is moving zigzag. So the light movements on the top of the head will tell where the patient is going. And you can also do posturography. Again, you have to have complex machines which are taking this data and giving you. But obviously, so many tests are there because it is not easy to pinpoint one cause. Unless it is DPPV, we know, okay, a patient give you clear-cut history. But if that clear-cut history is not there, then it becomes difficult that whether there is a problem in the ear, in the spinal cord, or in the brain. So all these tests, battery, we do to find out that what is, it is a multifactorial or it is just one point. Then for testing the cerebropontine angle, whether there is any lesions there, because these 5, 6, 7, 8 cranial nerves come out, you can do something called as corneal reflex. So you take a whisk of cotton and you touch the cornea of the patient and see whether the blink reflex is normal or not. Then I think Do we all know about this fistula test? So then other tests which can be done is postural test. You can do a Romberg's test. Okay. So this is just a diagram of fistula, video of fistula test, where you can see once the surgeon presses the so you can see that I will start spinning. And this is a patient of unsafe CSM. She had a history of surgery somewhere, and after the surgery, she developed this problem of nystagmus. This is a Romberg's test, and we can do this gender signal maneuver. So the patient can clasp his hand, and that will increase, like it will take the attention of the patient from the posture, and so we have no better result in this. So we can do a gait test where we ask the patient to move in a straight line. Then we can do a stepping test, which is called as a Unterberger test. So the patient is asked to raise the hands, and then alternately we do stepping up and down, and you can make out whether how the patient is whether is turning to one side or he is able to march on inside. So if it is falling to one side, that may be the site of lesion. Then there is one more important test which is called as a Hill's test. And do you know what this Hill's test? Okay, so there is a see, like in Western countries, lot of the patient management goes by protocol. See, so like they have a patient of acute vertigo. If and at that setting, they should be able to tell whether this patient is a patient of peripheral vertigo or it's a patient of stroke. So that, see, if it's a patient of stroke, they have to have that emergency protocol set in so that they are able to save the patient. So there's a paper which tells about this hint examination, so which will tell you broadly whether it's a peripheral or a central cause. So the hints may HI stands for head impulse, N stands for nystagmus, and TS stands for test for stroke, deviation of the eyes. So I'll just show you a video. Okay, so in the first, we're just telling that how we will do it.
Sound नहीं आ रहा है, देखो sound कर.
Observe the patient, having them look straight ahead. Just imagine yourself looking off in the distance without looking at anything in particular. In this particular case, you have a normal subject. There's no evidence of spontaneous nystagmus. The next thing we'll do is look for some haze evoked nystagmus, possibly direction changing, by having the patient pursue a target, such as the examiner's finger. So watch my finger as I move it slowly from side to side.
Pendulum suggests.
During this, we are looking for breakdown of smooth pursuit eye movements, and these pursuit eye movements are normal. And holding the eyes out laterally in the extreme position of gaze, we're searching for any nystagmus that evolves in a far lateral position. We'll hold the eyes there for a few seconds, and then do the same over on the other side. Again, looking for any sustained gaze evoked nystagmus that might be beating to the left when looking to the left, or to the right when looking to the right. After seeing no nystagmus, we want to make sure that the patient has no evidence of ocular misalignment vertically. So we'll have the patient again look straight ahead. This time, look here straight at my nose, and then simply cover each eye alternately. Keep looking straight at my nose. Keep looking straight at my nose. And looking for any refixation or movement of the eyes in response to the alternate cover test. We saw none. The patient has no evidence of strabismus or ocular misalignment, either vertically or horizontally. We saw vertical misalignment with concern. the patient has skew deviation. And finally, we'll take a look at the third element, the head impulse test of vestibular reflex function. We'll start by asking the patient to look straight at our nose.
We have one and a half hour lecture. 1:30.
From side to side.
मेरा सेशन कल भी कर
First slowly,
फिर लंच
a
कर
little bit
देंगे.
more quickly in a moment. Just keep looking straight here at my nose as we go. And turn your head a little more quickly.
खाना खा लेंगे.
What you can see that I'm doing is displacing the head laterally by approximately 20 degrees and rotating rapidly back to the arm. Same over the other side, rotating rapidly back to the arm. Key to the technique of this maneuver is that it's performed with a rapid head rotation, and generally it's best performed with the patient being unaware of which direction they're going. So often during the technique, we'll oscillate between slow movements and fast movements, paying attention to the fast movements, and sometimes change the direction.
I think it's clear that you observe for this head impulse and you see for nystagmus and you will see for the skew deviation. Okay? So this head impulse test is positive, that means there is a peripheral component of nystagmus. Okay? And if there is skew deviation present, then that means there might be a CNS cause, so you should start for the protocol of stroke. So this is a hint examination which is developed in the emergency setting. You do this hints test, and based on this hints test, you can start for the brain stroke protocol. And if you find that it's peripheral nystagmus, you can shift the patient on suppressive, labyrinthine suppressive, and don't need to go for any radiological investigations. Coming to the peripheral vertigo. So we can make out that the patient is having nystagmus on giving this head impulse test.
And giddiness also will develop, right?
Yeah. Patient will say, I am feeling giddy, and you will see that the patient is having nystagmus. This is showing you a unidirectional nystagmus. So we see that the fast component is towards the left, whether the patient is looking to the left or central or to the right. So for revision, abnormal head impulse test and nystagmus that does not change direction and negative skew deviation. That is the characteristic of a peripheral vertigo. If you want, you can look up the literature by putting hints test. There is a literature. If you want, I also have that paper which talks about this. Then there are two more tests. There is something called as Babinski wheel test and Balinese pointing test. In Babinski wheel test, the patient is asked to take 5 steps forward and then 5 steps backwards. And so I'll just show you a video of that Babinski wheel test. He's speaking some other language, so I'll not put some mind. So the patient is moving forward and backward. So patient who is normal. So this is a positive test where the patient bends straight and then he is not able to come back straight back in the same direction. And this is a Balinese pointing test.
In this video, I'll demonstrate how to perform the pass pointing test. I'll stand about a few feet from the patient. I'll bring my index fingers out about 6 inches apart. I'll have my patient bring both fingers up, sticking his index finger as well. Then I'll have him bring his fingers straight down and have him attempt to line up with my fingers. Then I'll have him close his eyes. He'll bring his arms straight back up and then bring him straight back down. And we're going to see if he's able to also match his fingers with mine as well, with his eyes closed.
Then coming to the very important Dix Pikes test or the positional test, which you all would have heard and seen.
Directing your patient is a long stay. If they have tight hamstrings or a low back issue, you may place a pillow under their legs to comfort. Position them so that when they lie on their back, their head will hang just off the edge of the treating table. Turn their head about 45 degrees towards the sides of the tester. Make sure to tell them to keep their eyes open at all times. For demonstrative purposes, we will test the patient's left side. One hand should be placed on their middle back to direct their fall, while the other hand cradles the head. Cue the patient to lie back quickly but safely. Make sure their head falls into a slight extension and remains turned toward the test side. They should not close their eyes. You should observe for unusual eye movements and changes to the patient's behavior. Updating the status indicates that the issue is in the posterior semicircular canal of the tested side. While on the other hand, downbeating the nystagmus indicates that the issue is in the anterior semicircular canal of the non-tested side. If you will not be performing the active maneuver, slowly assist your patient back into a seated position. Your patient is a long stay.
So this completes the test for the Vertigo assessment, and obviously if you think there are any cardiac issues, then you need to do blood tests or anemia, even metabolic diseases, ENT committee examination, hearing test, HRCT if there is any ear disease. Okay. So now I just there are various algorithms available. Is everybody okay? Should I continue or?
Yeah, no problem. Because
So-
this is a very tough topic.
Yeah, I think I also learned a lot compiling things for you, and I think I also learned a lot of things by compiling. So this is like an algorithm which you can follow. You'll find it in a lot of papers. So the patient is feeling dizzy. Okay. Now we already talked about this, that you can have a syncope like where the patient has a fainting sensation, and you can have disequilibrium where the patient is not able to walk, and normal odometry. Then most of it is probably vestibular migraine. Okay. Then if the third category is that the patient had a single continuous episode, sudden, lasted for 2 days and a very virulent course, patient had some history of viral, then it can be vestibular neuritis, where the virus has involved the vestibular nerve. So the patient can be managed with the Lazenheim sedatives, and he'll be okay with rest and in 1 or 2 weeks. And if it is resolved, no other workup is needed. Then comes the last, which we talked about, the HIMSS examination. So patient is having true vertigo, and we did a HIMSS examination where we might have found that head shake, the vertigo is not affected, and patient is having slew deviation, nystagmus is present. Then there can be a center radiology. So you will have to go for radiology, and in radiology, MRI is best. Okay, CT will not tell you good. So you need to do MRI urgently, and that is the whole purpose of having this HIMSS examination. So that, see, MRI is not that easily done and not a very cheap test. So it's a costly test. So this examination will help you which patients of vertigo will need an MRI. Then if you make a diagnosis, then good, you can start on those time. But if it's not made, then you have to think about very, very other rare causes. So we'll come to some videos of the various maneuvers which can be done. So Epley's maneuver for the posterior and the anterior semicircular canal.
So this is a demonstration of the Epley maneuver for a patient that has a problem with their right ear. First thing you're going to do is rotate the patient's head 45 degrees to the affected side, then rapidly lower them back, having their head extended over the edge of the bed by 30 to 60 degrees. Now we're going to wait for approximately 30 seconds to 1 minute for the patient's symptoms to resolve when they're facing the right ear, the affected ear in this case, to the ground. Then we're going to move their head 45 degrees to the opposite side, in this case the left side. After waiting 30 to 60 seconds in this position, we're going to rotate the entire patient's body, including their head, over again 90 degrees to the left. We're going to ask them to hold this position once more for 30 to 60 seconds, and then slowly have them return to an upright seated position with their head locked in to that 45-degree turn to the left side while looking down. This helps prevent repositioning of the stone. Then we're going to have them rest in this position for another 30 to 60 seconds before returning to normal. And that's
Then we'll see about the Simon's maneuver, which is for the posterior semicircular canal.
Another option to treat right posterior canal lithiasis is the right Simon maneuver. And so we turn the head away from the affected side and we go down on that shoulder, and the patient looks up towards the ceiling, and they stay there for 1 to 2 minutes. At that time, then we come in one movement all the way over to the other side, and they stay here with their nose down towards the floor for 1 to 2 minutes, and then we come back up into setting and head forward.
Repeat करो ये वाला.
Option to treat right posterior canal. Another option to treat right posterior canal lithiasis is the right Simon maneuver. And so we turn the head away from the affected side and we go down on that shoulder, and the patient looks up towards the ceiling, and they stay there for 1 to 2 minutes. At that time, then we take them in one movement all the way over to the other side, and they stay here with their nose down towards the floor for 1 to 2 minutes, and then we come back up into setting and head forward.
That will shift the stone.
Yes.
assesses the horizontal semicircular canal for the presence of displaced otoconia that is causing vertigo. To begin, the patient lies in supine with their head in midline and pitched up 30 degrees. Maintaining the same position, the patient's head is turned to either side. In this position, the examiner will be looking for horizontal nystagmus. This is also performed on the opposite side. Depending on the direction and duration of the meeting, various conclusions can be arrived at. Beating towards the ground is known as geotropic nystagmus and may be indicative of canal lithiasis of the horizontal canal. Whereas beating away from the ground is known as apogeotropic nystagmus and may be more indicative of tubular lithiasis.
Next, the physical therapist
तक
will
शुरू
rotate the
करेंगे ना.
patient's head 180 degrees to unaffected side and hold